I'm Tom Stinchcombe. I'm a medical oncologist who specializes in thoracic oncology. I work at Duke Cancer Institute in Durham, North Carolina. I think the question of when to read biopsies is a frequent conversation I have with patients and we have with other providers. I think the times that rebiopsy are really critical is when there's some ambiguity about whether this is actually disease progression versus another primary. In other areas that we've seen with some of our targeted therapies, particularly EGFR mutation positive patients, they can undergo histological transformation from non-small cell to small cell. And if they undergo that transformation, generally I've treated with a platinum etoposide backbone, so it fundamentally changes the therapy. And I think there's increasing interest in that there's genomic evolution within our cancers that we treat, especially if we give them selective pressure with targeted therapies or immunotherapy. And it can rebiopsy help you guide the next step in the therapy. I think that this is a high priority among the research community, and it's going to be the next step forward as we develop drugs for immunotherapy refractory patients. I think when you go to routine clinical care, it's a much more debated question on when to do it and what the value of doing it is. And I think that it's sort of done on a case-by-case basis, depending on where the spot is, what future therapies I have to offer that patient. And one of the big questions I often ask myself is this going to really change the therapies? Am I going to be able to offer a new drug, a new trial, a new option to the patient? In those cases, I feel much more comfortable doing the biopsies. I think inevitably the patient's going to ask, well, what's the risk of the biopsy in terms of what's the benefit? And I think there's sort of two broad ways that we biopsy patients. One is by bronchoscopy. And with the bronchoscopy, many times there's sedation. And, it's done by an interventional pulmonologist who does biopsy, but the risk of pneumothorax or collapse of the lung is low. But there is an inconvenience of going through another procedure. The other way we biopsy patients is through CAT scan guidance. And I think this has a higher risk of pneumothorax. The risk of pneumothorax sort of varies depending on where the location of the lesion is, or if there's underlying lung disease and other factors. So most of the time I have a conversation with my interventional radiologist, and they're very candid that yes, we can do this one safe and it's feasible, or no, it's not. And I think that's one of the many things that we do behind the scenes to ensure safety and quality. Biopsies of other lesions, such as in the liver, generally don't have the risk of the collapsed lung. The big risks are bleeding and infection. I think what you have is, I would estimate the risk of these procedures about 5%. And I think if you go look at retrospective studies that do that, that's approximately what it is. I think the one that's most problematic to the patients are, of course, the risk of the collapsed lung and the potential to be hospitalized and other aspects. And so that's the specific risks that I think we triage most carefully.